Hi, everyone. We hope you're well and safe. My name is Bei Wu. I'm Dean's Professor in Global Health at NYU Raleigh-Myers College of Nursing. If this is your first time hearing about the NYU Aging Incubator, I would like to briefly take a moment to introduce our initiative. The NYU Aging Incubator was established in 2016 as a university-wide initiative that bring together faculty and students from across the university, and also actually across all disciplines who are involved in the study of aging and its impact on society. The NYU Aging Incubator aspires to be the resource for the NYU community to grow research, educational activities, events, and resources for all who work in the aging space or are interested in doing so. We are committed to the improvement of the health and the well-being of older adults through innovative and interdisciplinary research, policy development, and educational endeavors. On behalf of the NYU Aging Incubator team, our co-directors, Dr. Josh Chodosh and Vicky Rivas, I would like to thank you all for joining our webinar today. I'm very pleased and honored to introduce our guest speaker, Dr. David Grabowski. Dr. David Grabowski is a professor in the Department of Healthcare Policy at Harvard Medical School in Boston, we should all know. So his research primarily focuses on the economics of aging with an emphasis on post-acute and long-term care financing, organization, and the delivery of services. He has published over 175 peer-reviewed papers related to these issues. Dr. Grabowski is a member of the Medicare Payment Advisory Commission, and he has served as a member of multiple CMS technical expert panels related to post-acute care payment and quality reporting. He was also a member of the CMS Coronavirus Nursing Home Commission. Today, he will be discussing the devastating impact of COVID-19 on US nursing homes and explain why nursing homes have been ground zero for this pandemic. Please stay tuned for Q&A session during the last 15 minutes of our webinar. Without further ado, I would like to give Dr. Grabowski a few minutes to introduce himself and also start your presentation, please.
Great, thank you, Bei, and hello, everyone. I was just telling Bei, I wish we could all be together in New York City today, but we will get back to normal hopefully sometime soon. So thanks to everyone at NYU, Bei and Vicky and the whole team for inviting me today. Great to spend some time with you, and I look forward to your questions at the end of the talk. So as Bei mentioned, I'm gonna do several things with my time. First, I'm gonna review just the kind of devastation that's occurred over the past year plus in nursing homes due to COVID. I next want to talk about why some nursing homes have been particularly hard hit and others haven't, and really think about whether we can assign some potential blame here in terms of why such a devastating impact of COVID. And then I will turn and talk a little bit about some potential solutions, both short-term and then also kind of longer-term, thinking about how we fix this sector such that we don't have this in the future. And finally, I'd like to end on a brighter note and think about a little bit about vaccinations and just kind of the road forward here. So let me start back in March of 2020. I published a piece in JAMA Health Forum at that time with Michael Barnett. And I know it's very common for academics to want to pat themselves on the back and say, hey, I was right. And this is the one time in my career I really wish I hadn't been right, because Michael and I kind of sounded the alarm, as many others of you probably were doing this, and many of us were saying, we need to pay attention to nursing homes or this could get really bad really quickly. And unfortunately, I don't think policymakers listen to us. And as Bei mentioned, nursing homes really did become ground zero for the COVID-19 pandemic. And just to give you some numbers, and these are really just staggering, the devastation. And we can start just with the number of cases and deaths, but they're to date, and these are the data that encompass both nursing homes and assisted living facilities. We've had over 1.4 million cases in over 34,000 facilities, leading to over 182,000 deaths. Just staggering numbers that really speak to the devastation here of COVID in this sector. Unfortunately, we didn't have federal nursing home data from the start of the pandemic. But we are able to do some comparisons of the US versus other countries just for all long-term care facilities. You can see that the US is not an outlier by any stretch. We're really an inlier here. There's some Asian countries on the left here that have a relatively low share of overall COVID deaths in long-term care facilities. And then there's countries like Belgium, Canada, and Australia that were out to the right here. These data were reported by longtermcarecovid.org, which is a group over at the London School of Economics, which is really doing great work in tracking the pandemic globally. One of the things that has been noted is that these numbers are from early February, probably January, when they did the data collection. The US numbers actually come down, and that speaks to just the huge effort we made in vaccinating our long-term care populations here. And currently, in terms of the percentage of all COVID deaths in long-term care facilities relative to the total, it's about 1/3 today. So we've come down. Other countries have probably come down too, but things are definitely looking up. But you can just see that this wasn't just a US problem. This was an international problem in long-term care systems around the globe. Given we didn't have nursing home data from the start of the pandemic, we unfortunately couldn't track New York City and New York State, where you were hit particularly hard early on in that March through May period of 2020. The federal nursing home data start in that last week of May, and you can see we were just kind of having that first decline. We then had a spike in the Sun Belt states there during the summer of 2020, and then we had that really third surge, if you will, during the winter months of 2020 into 2021. And I want to come back to this at the end, but you can see we're doing quite a bit better today, just given vaccination efforts of late. What does New York State look like? Once again, unfortunately, we missed that big first surge in New York State in that March to May period, but you can see things were once again coming down. You really didn't have a surge over the summer months of 2020, but a really big surge during those winter months, and then things are also looking quite a bit better in New York State today relative to what they were over those winter months. We did a paper. It's actually interesting, where I can provide some very direct data on the impact of the pandemic on New York City. So unfortunately, early on, as I mentioned, we didn't have data on nursing homes particularly, and we couldn't really see what was the kind of mortality burden of the pandemic. And what we were able to do is we partnered with a group that had electronic health records for nursing homes in 3 cities, Cleveland, Detroit, and New York City. And we were able to look at what does the excess mortality in 2020 look like relative to, in orange there, relative to the blue line of deaths in 2019. And these are overall deaths, so they encompass both COVID-related fatalities and other deaths. And you can see in Cleveland, there was no statistically significant difference. In Detroit, there was over 2.2 times higher deaths in March through May of 2020 relative to 2019. In New York City, over 4 times higher mortality during that period in 2020 relative to 2019. So we know New York City was kind of the one of the epicenters for COVID early on, and you can see that in these data. And just, I don't know if you can see my cursor here, but that apex, that week where things were at their worst in New York City, deaths were over 10 times higher in that week relative to that corresponding week in 2019. So safe to say New York City was one of the places hardest hit by COVID in nursing homes early on. It wasn't just that COVID had this high rate of on cases and deaths. It also just changed the entire culture within these facilities. Most nursing homes around the country had to close to visitors. There was no communal dining or activities. And there's been some really strong work by the Altarum Institute, where they went out and surveyed over 300 residents across 36 states. And just they showed how limiting the pandemic has been on the life of residents, whether that's decline in visitors, outside activities, the ability to enjoy fresh air, the ability to enjoy communal activities, or even to eat together in a dining room. And also from that Altarum report, you can see that this is whether after the coronavirus restrictions, whether residents felt more lonely than usual. And you can see that over half said yes by a lot, nearly 19% said yes, but just a little, and less than a fourth said not more than usual. So this is not whether you're lonely. We know there's high rates of loneliness at baseline in nursing home populations. This is, did you feel lonelier than usual? And over 3/4 of residents were lonelier than usual. Huge mental health impacts of the pandemic on residents, failure to thrive, weight loss. It's safe to say that it's more than just COVID that's harmed nursing home residents. It's also been the pandemic more broadly. A lot of people have asked, given we know nursing home residents need contact, they need socialization. Why did we close nursing homes? Why this lockdown? I was involved in some research studies here in Massachusetts that helped show why I think in a lot of states we acted so swiftly to close nursing homes. So this was an effort on the part of the state of Massachusetts. They partnered with some of the big hospital systems here in Massachusetts to go out and find specialized nursing homes that could become, a COVID-only facility. So in order to do that, they went out and identified these facilities. And on April 1st, the team went into a facility in Wilmington, Massachusetts, that had 97 residents. They had no known symptomatic cases. There was no COVID as far as the leadership in the buildings were aware. As far as the medical director, we thought these were clean facilities. It turned out on April 1st, all 97 residents were tested. 52 tested positive for COVID. On April 5th, those remaining residents who didn't test positive, so those 45 residents who had initially tested negative were tested. 31 of those tested positive. So now we have 83 of 97 residents having tested positive. We also tested the staff on April 6th, at least 97 of the staff, 36 of them tested positive. By April 15th, 30 residents had died of COVID. So we're going from late March, no COVID in the building, no known symptomatic cases, to basically just over 2 weeks later, 30 residents had died. This shows how quickly this happened in New York City. This happened here in the Boston area, and it happened obviously ultimately in a lot of states around the country. But things moved very quickly in terms of the progression of COVID, and that's why I think policymakers were very quick early on to close buildings to visitors, to close them to communal dining. I'm going to come back to that point. I don't necessarily agree with the way we did that, but this was the rationale for it. COVID wasn't just hard on the residents. COVID was also very hard on nursing home staff. We've seen to date, and this is just from the late May on data that the federal government has been collecting, over 500,000 confirmed cases. You can see over 1,800 staff deaths. We know that staff often lacked personal protective equipment. They lacked access to rapid testing. In many instances, we didn't treat them like the heroes that they really are. Unlike hospital workers or other healthcare workers, they weren't given hazard pay. They don't have benefits like paid sick leave. So we really asked a lot of this workforce, but didn't give them a lot back in return. final point I wanted to make on just kind of the impact of this pandemic was just how tough this was in terms of the business model for skilled nursing facilities. And going back to that piece we did in JAMA, this is just looking at new admissions and overall census. So the top row across Cleveland, Detroit, New York City, and you can see admissions came way down. They came back in Detroit, and you can see they go up in New York City and then back down. I think New York City, some of that may have been the governor's mandate that you probably have heard about for nursing homes to admit COVID positive patients from the hospital. But ultimately, you can see the decline in census across the three cities, and that happened nationally and has continued to happen, where we have much fewer residents in nursing homes today than we did a year ago. Some may say that's a good thing, but it really speaks to maybe some real changes in how we may organize nursing home care going forward in this country, and I'll come back to that issue. I want to pivot now, having kind of outlined the impact of COVID on nursing home residents, staff, and kind of the business model more broadly. I want to talk about kind of who's to blame. And I know that we all know that the real villain here is COVID, but there's been a lot of efforts by policymakers, by reporters, by academics to try to kind of pinpoint why certain nursing homes were hard hit and others weren't. And there's different explanations or hypotheses out there. First, it may be something about these nursing homes themselves. Maybe they had poor infection control. Maybe there's simply bad actors out there, and that's why we're seeing certain nursing homes get hit and not others. Of course, we've heard a lot about state policies. Most of that discussion is centered around New York State, but we know that there were particular policies like that mandate I mentioned in New York State that really kind of may have contributed to cases in nursing homes. And then a final explanation is just that this was a system-wide failure, and COVID in nursing homes kind of just tracked where COVID was in the community. We didn't control it in the community, and it made its way into our nursing homes. And so these obviously aren't mutually exclusive. They all can be true, but we kind of set out to think about what are the characteristics, what are the drivers of COVID occurring, these outbreaks occurring in particular facilities and not others. And very early on, we did a piece that was led by my colleague. She's now at MGH, Hannah Abrams. We looked at, why is COVID in certain buildings and not others? And we used data from 30 states, including New York. And what we wanted to kind of analyze are what are the variables or characteristics that are correlated with outbreaks, and what variables are unrelated. And it was interesting. I'm including a graphic there on the left from the Wall Street Journal. Not surprisingly, their graphic is much prettier than our graphic. But they covered our paper in early June, and basically what was related to COVID outbreaks at that time was home size. So larger facilities, not surprisingly, more asymptomatic staff going in and out of the building led to more cases. At that time, COVID was much more centered in urban areas, and hence urban facilities were much more likely to have COVID. And then facilities with a larger share of Black residents were more likely to have COVID. Once again, we know minority communities were particularly hard hit early on, and that led to more COVID being in nursing homes in areas. Thinking to hear that nursing home care is local and staff work in area nursing homes, and staff once again asymptomatically bringing this from the community into the nursing homes. What variables weren't correlated with whether or not there was a COVID outbreak? The 5-star rating. It wasn't the case that worse rated facilities had more COVID cases. There was no correlation with having a prior infection control violation. We didn't see any effect on for-profits, chain-owned facilities, whether or not even they had a greater share of Medicaid recipients, which is typically a strong predictor of quality of care problems. All of this led us to conclude that it was much more about where you were than who you were. And this wasn't about being a bad actor. That's not to say nursing homes couldn't have done anything. It's not to say states didn't adopt some bad policies. There were bad actors, there were bad state policies, but the driving force here we found was really across all 30 states. It was really about whether or not COVID was in the surrounding community. And you can see that going back to that JAMA piece we did early on across Cleveland, Detroit, and New York City. The top is just total weekly deaths from COVID in the broader metro area. And then once again, you've already seen the bottom trend there. That's just nursing home deaths. And you can see just how closely at that time, overall community deaths paralleled nursing home deaths in Cleveland, Detroit, and New York City. There was, when COVID is in the surrounding community, it's really hard to keep it out of nursing homes, given staff are going home every night and into these communities, which are particularly hard hit, and then coming back into the nursing home the next day, especially when they lacked PPE and rapid testing. This result, along with similar results that my colleagues Tamara Konecka at the University of Chicago and Vince Moore at Brown University, led us to do a Washington Post piece back in June of 2020, where we argued that we need to protect everyone. This isn't about penalizing. We're not going to get out of this by coming down really hard on the worst actors. Once again, there certainly were some bad actors and some facilities that didn't do everything they could, but the vast majority of outbreaks were really about this need to protect all of our facilities, not about really a few outliers here and there. And so we made that argument. And as Bay mentioned during the introduction, I was a part of a CMS Nursing Home Coronavirus Commission that kind of looked at the early evidence and thought about what CMS could do to really protect nursing home residents. And we met over the summer months of 2020, and then we released our report to CMS in the fall, September, October 2020. Even some of the commission members went and met with Vice President Pence at the time to kind of talk about how we can implement these different actions. So we recommended sort of 10 areas that CMS could really work to improve residents and staff in nursing homes. And those are in green here. This is just from our, taken from our commission report. These 10 theme areas led to 27 recommendations and over 100 action steps. So I will say a couple of things. One, I still believe these steps would have really protected nursing home residents had we taken them. Unfortunately, and this is the second thing I'll say, CMS didn't largely take these steps. They used our report to sort of say, well, we're doing all of these things, or doing something in all of these things, and kind of took it as a mission accomplished moment rather than a kind of a call to arms, and really didn't move forward in a significant or serious way in doing this. And by the way, the GAO has written a couple of times about this issue and said CMS largely didn't follow our recommendations here. I wanted to talk about a few of these areas and how CMS really failed our nursing home residents and our staff in terms of really following through with this. And I want to talk about workforce. I want to, all the big issues we kind of list here: testing, equipment and PPE, visitation, and workforce as being a few of the areas that we kind of outlined here that really could have helped. The first and most obvious is testing. This is from a piece back in May of 2020. My colleague Michael Barnett and I published in the LA Times, suggesting we're not going to get anywhere without rapid testing. I mean, that's first and foremost the most important thing. Given staff are going home every night, if we're not testing them the next day, we're not going to be able to protect residents. And I can't say this enough, how important it is that this is rapid testing. PCR testing we know is more accurate, but antigen rapid testing was really what was needed, because you can't wait even over a day or 2 days at a nursing home for potential results. And I'll just tell a quick story from New York State. At one point, your state had a requirement that the state that you had to have all staff tested twice a week. And at one point, I was talking to an administrator after this policy had been implemented, and it was a Thursday that we were speaking, and he mentioned he had been tested on Monday, and right after we spoke, he said, "I'm going for my second test of the week. I'm still waiting on the results of my Monday test, but I need to go get my second test in order to be compliant with the state." That makes absolutely no sense, right? Like, that's just checking boxes here. If we can't get the results of those tests and actually put them into practice, if he had been COVID positive, he had been at the nursing home since Monday, interacting with staff, obviously with PPE, but this totally defeats the purpose if we're not able to get these results in real time and turn them around and implement them. CMS recognized this and implemented in July, on July 14th, they put forward rapid point of care antigen-based testing at all nursing homes nationally. So the idea was that facilities would be able to do 20 tests per hour, up to 4 to 5 million per month nationally. So CMS provided the testing kits, sent them out to all nursing homes, and they started, if you'll recall, with those nursing homes, those 2,000 nursing homes in markets that were most at risk. And then the idea was to start with those kind of hotspot areas and then roll out to facilities nationwide. And we did a piece in JAMA Internal Medicine, led by my colleague, Brian McGarry, who's at the University of Rochester. We looked both nationally for residents on the left, and then the lower left there in blue for those hotspot counties. We looked in late August, and then we looked in late September, and we did see some improvement with the federal rollout. But whether you're looking at nationally for residents or looking in green there for staff, whether you're looking overall or in hotspot counties, you can see, look at the numbers of less than a day, which is really what we need to protect residents. Very low share of nursing homes were actually turning around their tests in less than a day. That's why we couldn't contain this virus. We didn't have kind of the rapid testing in place. The other issue that just plagued us from the beginning of this pandemic was the lack of personal protective equipment and adequate staffing. This was another piece led by Brian that we did in Health Affairs, where we looked at kind of mid-May to mid-June is study period one, and then kind of late June to late July is study period two. And you can see basically 1 in 5 facilities at that time had a personal protective equipment shortage, and roughly 1 in 5 had a staff shortage. The PPE supplies got better, but never perfect. So the fact that we could never get N95 masks to everyone, that we could never get supplies out to every facility nationally, was really a huge gap in protecting staff and residents. And then the staffing shortages never really got better. We've seen this pretty persistent staffing shortages, severe staffing shortages that went way past the summer of 2020. We also surveyed 223 nursing home administrators over the period July through September of 2020. We published this recently in JAGS, and we just wanted to ask them what were the biggest challenges over the past 30 days, and then what do they think are the biggest challenges for that next wave that ultimately occurred over the winter months of 2020 and 2021. Not surprisingly, they outlined exactly the issues that we took on in that CMS Coronavirus Commission report: staffing, COVID-19 protocols and requirements, keeping up with supplies, testing, visitation. These were the issues that CMS should have been focused on from the beginning. This is what SNFs were concerned about, had trouble meeting, and were worried about going forward. And whether you look at kind of kind of the data that were out there or what they're telling us about their challenges, it was really unfortunate that we weren't able to provide adequate support to nursing homes over this pandemic. I want to focus a little bit on staffing because I think this is an area that's been a longstanding issue. We came into this pandemic with low staffing in a lot of buildings around the country. A large part of this was due to just what staff are paid. It's really hard to attract and then retain workers in this sector. And so we did a piece, sort of back in May of 2020, suggesting, we're sort of upside down with the staffing issue. We loved responding to a crisis, but why aren't we sort of taking good public health measures of actually being proactive and protecting residents beforehand? And we make the argument that we could increase the pay of CNAs nationally by $10,000 a year, $5 an hour. That would add up to what is a big number, 20 billion. But when you benchmark that against what we spent in fighting COVID over the first 6 weeks of the pandemic, it's less than 1%. So this is a relative drop in the bucket. We spent a lot fighting COVID. It's too bad we didn't put this into practice earlier on. I think we would have had much fewer staffing shortages and much more support. And it's been nice to see, as an aside, President Biden really focusing on home and community-based services and supporting the workforce there. I would love to see some additional dollars flow to the staff in nursing homes as well. One of the reasons that I've been so focused on staff during this pandemic is just the burden that they, I mentioned earlier, over 1,800 staff have died since the start of the pandemic. And this led my colleague, Brian McGarry, once again to wonder, what's the death rate for nursing home workers look like relative to other professions? And so we went back, this is pre-pandemic, January 2020, they run this Most Dangerous Jobs in America piece. They probably do it annually. You can see logging workers at the time ranked #1, commercial fishermen #2, and you can see logging workers just under 100 deaths per 100,000 workers. And we wondered, what do nursing home workers look like relative to these other professions? And sure enough, at the time, we estimated that if the death rate continued, we would see 200 fatalities per 100,000 workers, making nursing home worker the most dangerous job in America. And we co-authored this piece with Lori Porter, who's the head of the National Association of Healthcare Assistants, the largest group of CNAs in the country. We failed here to really protect CNAs, and we write in this piece, they deserve better. And I think this piece really opened a lot of eyes, because I think when we think about the most dangerous jobs in America, I don't think nursing home worker is one that we typically gravitate towards. But these death rates continue, even if you go into the most recent CMS data. Every week we're seeing 20, 50, 60 deaths of nursing home staff. So this issue by no means is over, and it really speaks to just how in many respects we failed to support this workforce. This led me recently to publish a piece thinking about some ideas. There's been some really big thought pieces, which I have written some of them, but this was a very direct piece about how do we, given nursing home staff is the most dangerous job in America right now, how do we improve this going forward? And not surprisingly, the ideas I put forward in this Politico piece last month were about minimum staffing standards, increasing pay and benefits, raising, we're going to have to pay for that, raising reimbursement rates. We want to make certain that reimbursement goes to staff. And so I also called for increased financial transparency and accountability. We also want to improve these jobs and make certain there's opportunities for career advancement. If CNAs want to become LPNs, for example, we also want to improve the working environment. So I'm very supportive of kind of ways of making this a better job going forward. Final issue before kind of pivoting to kind of where we go on a kind of broader policy level was this issue of nursing home visitation. And I mentioned earlier why we did this, just kind of the risk of staff and visitors and everybody bringing this in. And one way to kind of protect residents was to keep family members and friends out. And I argued in a piece with Jason Karlowicz and Allison Hoffman at Penn that keeping what we called for was we needed to establish essential care partners. These were not social visits. This was not somebody just coming by to chit chat. These were really a part of the care team. And by keeping these individuals out, it really led to more harm than good. That yes, the pendulum swung towards safety, but it really swung away from quality of life, from resident dignity. And the idea that we could take over a year and not have any kind of families or loved ones in these buildings was really, I think unfortunate and really bad policy ultimately. CMS did, it's worth noting, update their visitation policy last month to increase visitation. And even just this week, CDC updated their guidance that now fully vaccinated residents can resume dining without masking or social distancing, and also permitting additional visitations and not needing masks if they're vaccinated. And so we're getting back to normal, but it's been very slow and challenging. And I think something going forward that protecting residents and maintaining visitation from these essential care partners, I think is something we'll want to do for the future. So kind of pivoting here and just for the last few minutes before opening it up for questions, I did want to kind of talk about the broader policy environment for nursing homes. I've called this a crisis on top of a crisis. And what I mean by that is we know what COVID-19 has done to nursing homes. I've been talking about that for the last 25 minutes plus, in terms of the death rate and that death rate being concentrated among minorities, residents, even in buildings where COVID wasn't present, being isolated and lonely, just the impact on caregivers and the impacts ultimately on the nursing home sector. You layer that on top of a longer standing crisis where we've had low Medicaid reimbursement, poor quality, low staffing, low wages for direct caregivers, huge disparities across buildings by race and other variables. Too few clinicians in these buildings, ineffective regulation, an inability to sort of follow the money and to really observe quality, and then the influx of private equity and other ownership structures. And so suffice it to say that yes, COVID-19 has been hard, but this was not hitting a part of our healthcare system that was strong at baseline. We've had a lot of longstanding issues in nursing homes that really were magnified during the pandemic. So what do we do about this? I've written several pieces, and I'm just gonna kind of outline them here quickly. A piece with Vince Moore that we published in JAMA, a piece in the Commonwealth Fund, which I'll talk about a little bit more, and then Joe Oslander and I did a piece in JAGS, just kind of outlining kind of future directions. And all of the not surprisingly, I wrote them all, so they're all kind of consistent in sort of messaging. But I just wanted to kind of outline some of the ideas put forward in the Commonwealth Fund issue brief. A big problem I see is just that we have Medicare, which is a very generous payer for post-acute care, Medicaid for long stayers, which is not a very generous. We need to realign and better pay around costs and address the fragmentation that these two payers introduce. We need policies that encourage clinicians on site. We, once again, and I already talked about this, need to support caregivers in terms of both wages and numbers of staff. We need greater quality transparency. Nursing Home Compare, I think in a lot of ways, is not capturing what's most important to residents and their family. We need to improve regulation of facilities through better enforcement and quality improvement. I'm a big believer in small home models like the greenhouse. I think many of our nursing homes are way too institutional. I noted that occupancy rates are way down. This is an opportunity, I think, to really think about the capital structure. Most of the capital that's out there was built in the late 60s, early 70s. Think about like cancer care or other parts of our healthcare system. We're not using the same kind of technology or capital we used in the 60s and 70s to treat cancer. And really, we shouldn't have the same buildings that we constructed back then. We know a lot more, and individuals want a more home-like environment. We should have homes that are resident-centered, not these big 100-bed institutions. And I think this is an opportunity to kind of strengthen this. And by the way, smaller homes were much better at protecting residents because they had much fewer staff coming in and out of the building. I love what's happening right now in the investment in home and community-based services. Far too many individuals end up in nursing homes that don't need it. The best way to improve nursing homes is to strengthen home and community-based care, but we can't do one without the other. Oftentimes, I think they're held up as kind of either or. I actually think it's complementary. You need to invest in home and community-based care. We need to invest in nursing homes. And finally, it's great that we're making all these investments in Medicaid, but you have this forgotten middle. And how do we actually support that group as well through some sort of national long-term care benefit? Just as point again, I published a piece in Nature where this is a false dichotomy to hold up HCBS versus nursing homes. Let's invest in HCBS, but let's also transform nursing homes to these smaller models like a greenhouse or other model that really values staff and residents. Final point, and I wanted to end on it's been I know sort of a gloom and doom thinking back over the past year, but at least over the last several months, we've seen a strong effort to vaccinate residents and staff. We've obviously done better with residents than staff. There's been some hesitancy on the part of staff, but you can see here just the numbers in blue, kind of the daily vaccination rates, and then in orange, the cumulative rate. We have over 7.5 million vaccine doses administered among residents and staff in long-term care facilities, including nursing homes and assisted living. And it's made a difference. This is just from the New York Times, but you can see kind of where we started. Nursing home vaccinations led overall vaccinations. They were prioritized, and deaths in nursing home residents came way down, whereas deaths in the community continued to increase. And I mentioned this earlier, deaths as a share of overall COVID deaths in long-term care has continued to decline relative to the overall COVID death rate. I call this my new favorite picture. I know this isn't causal, it's correlational, and some of the decline happened even before we began the vaccine rollout there in yellow, but you can see that we've done pretty well in terms of continuing to bring down that vaccination rate and keep it down at levels that we really didn't see over the past year. I think it's important, once again, that we get more of our staff vaccinated. And so these are just the sort of departure at the US level and in New York State, where many of you live. You can see in blue there, that's the confirmed resident cases, and in orange, that's the staff cases. Not surprisingly, resident cases, which had tracked staff cases pretty quickly, are now below the staff cases. And I think that's just, we've had more hesitancy among staff. Given that many staff aren't yet vaccinated, and given this huge issue of staff turnover and new residents, we need to keep vaccinating. And final slide, I wrote a piece in the Harvard Health blog back in February, just sort of suggesting we know we need to get the rate of vaccination up. And one idea that's obviously out there is mandates. Should we mandate? And I think in the short term, given the emergency use authorization of the vaccine, we're not going to see mandates by most nursing home chains in the short term. But maybe after the EUA status ends, potentially some will mandate. And I think that'll have the intended effect of increasing vaccinations. but it may have the unintended effect of causing some staff to leave. And so once again, we're going to really need to be careful about how we implement this and how we think about ways of encouraging vaccination. There are other ideas out there like paying staff to get vaccinated. I think we need to be really thoughtful here, or else we really could risk further individuals leaving this workforce. I'll stop there and say thank you, and hopefully there's some questions. I'm happy to answer anything. So, Vicki, I don't know if you want to have folks ask, or were you going to ask? I'm happy either way.
Okay. Well, we do have a couple questions from the audience. So what I will do is I'll read the questions out to you, and you can then comment that way. That'll be an easier way of progressing.
Sure.
So, okay. So the first question is, if the main factors for U.S. nursing home outbreaks were whether COVID-19 was in the community, would it be safe to say that these were also the factors for low outbreaks in countries such as South Korea, Singapore, or Hong Kong? Or was something else, such as cultural factors, playing a role in these countries that was managed better? So how might this impact how best to handle things in the U.S. if we bring in the global context?
Yeah, great question of what we can learn from other countries. So I very much believe some of this is just community spread, and we certainly saw that in some of the Asian countries where they did such a better job of containing this in the broader community, and so they had much lower rates of deaths in their nursing homes, and that was kind of certainly there. The other issues that individuals have pointed towards are, one, sort of the size of the facilities, kind of their ability to access personal protective equipment, their ability to use rapid testing. So I do think some countries were better than others. And what was interesting about that figure is that there are countries that I think are much further ahead of us in terms of universal healthcare coverage, like Canada, for example, but has struggled even more. I joined a panel recently at the University of Toronto, and they gave me the opportunity to gloat over how well the US has done. Well, do you think anything about my presentation suggests we've done well as a country? Like, we've done terrible, yet we've actually done better than Canada, because their long-term care system shares a lot of the same problems we do. Big nursing homes, they didn't invest in PPE, they didn't have testing. And so I do think there's some stuff that can be learned, and I think the lessons we saw here in the U.S. Are certainly present around the globe.
Okay. The next question is, given the problems with long-term care facilities, do you think we will see an expansion of home-based long-term care programs, such as the PACE programs, post-pandemic?
I absolutely believe that to be the case, and I think that's should be the case. I think one of the most important developments in long-term care over the last 30 years has been investment in these kinds of programs. Some states have done much better. New York has done relatively well, Minnesota, Oregon, but other states have not done so well. And so how do we encourage that kind of investment across the board? We have far too few areas where there's meaningful investment. And so I do think that's a big part of the future. I will reiterate the point I made during the presentation. I find it a false dichotomy to say you invest in one without the other. We need PACE, we need strong home and community-based service models, but we also need strong nursing home models. Not everyone will be able to receive care in the home or the community. For those individuals going into a nursing home, how do we make certain that's a home-like environment, a small home environment where the staff are valued and the residents have control over their life and families are engaged in the care? We can do both here.
Okay. What sort of leads into that particular question is, with the various guidances that you have of recommendations, what do you think are some feasible paths for financing these changes?
Yeah, everything I put forward is going to take money, right?
Mhm.
And we can say, for example, we need minimum staffing standards, and many people think there are currently abuses on the part of some nursing homes, and I would agree with that there's some nursing homes, private equity groups, that are not putting all of the dollars back into direct care. And New York State, for example, is looking at legislation right now that's going to require nursing homes to spend sort of a minimum amount on direct care. And so California, New Jersey, other states are looking at similar legislation. I think there's good reason that a lot of us have been suspicious, but I don't think simply identifying the bad actors here is going to get us kind of all the way there. It's going to take more dollars, and that means, when we step back, who are the big payers here? It's Medicare on the short stay side, and it's Medicaid on the long stay side. And I think ultimately it's going to take more Medicaid dollars. And in order to make that happen consistently and uniformly across states, we're going to need to see the federal government step up. And ultimately that might be federalizing care for these long stay residents. But we can't get there alone with the dollars that are in the system. I fundamentally believe that the system is underfunded, but it's also, we need greater accountability and transparency. So both of those things are true.
Okay, related to that, the idea of, do you think part of the issues is we're talking about state control and funding issues versus national? Do you think there has to be a broader national plan involved, or still keep it at the state level?
This is one of those great questions, because we've largely had, federal health care through Medicare with obviously some Medicaid coverage, but we've kind of federalized the healthcare side, yet left long-term care largely to the states. And I think some states have done a great job in providing, a real broad set of services to older adults, but many states haven't. And so I do think if we're going to address this kind of fragmentation that happens, where I can be an older adult living on one side of a state border and have access to very generous coverage, and then on the other side of that state border, I have very, very little. It strikes me that we need to bring that up. And so I do think there's a greater role for sort of federalizing some of these benefits. Who actually then controls it is a broader issue. But I like the idea of federalizing these benefits. The other part of the question is whether you still have a group, even if you federalize Medicaid, that's kind of in that middle I mentioned earlier, where they're currently too wealthy for Medicaid, yet not wealthy enough to really self-finance their long-term care. We did a piece in Health Affairs a couple of years ago called The Forgotten Middle. And it's really like policy doesn't kind of address that group. And so I'm hopeful that kind of we can think about long-term care benefits in this country, where we're moving past just the kind of current sets of funding and really thinking about whether there's broader coverage. Because even with the President Biden plan right now to invest in home and community-based services, that's via Medicaid. You have a lot of older adults who have service needs that aren't going to be able to afford those, and are ultimately going to impoverish themselves because of a lack of a long-term care benefit.
Thinking now in terms of the nursing home staff, what are some of the things that might be able to be done to improve the skill mix of the staff as a way of helping to improve quality of care and reduce infection control issues?
Yeah, so this goes beyond, I was largely focusing my remarks on sort of the direct caregivers, but also the RNs and the LPNs. And clearly we need that skill mix. But one of the big pushes, and we talked about this a lot on the CMS Coronavirus Commission, was the role of the infection preventionist. And that was a role that I think was underinvested in prior to the pandemic. Could have really helped. And so that's certainly a part of the kind of staff skill mix that could really help here. And then kind of stepping back, I've called this, others have written this, that physicians have largely been missing in action in nursing homes, as have nurse practitioners and other clinicians. We need more clinicians beyond just this infection preventionist and beyond RNs and LPNs. We need to sort of fill out and figure out models. And we did a study, for example, of institutional special needs plans, or ISNPs, which is a special type of Medicare Advantage plan. That's one way of getting a nurse practitioner into the building. There are other policy mechanisms, but the idea that you can have this number of dependent residents without having clinicians on site is just, it's really failed our residents. And so I'm not saying we need to medicalize this care. Rather, we need to provide these residents with on-site access to these services.
Now, here's a question that focuses a little bit more about how to improve the structure of homes. So what do you think of the marriage of PACE and smart technologies in the design of new generation small home nursing homes as a way of helping older adults age in place?
I love those kind of models. And PACE, the principles around PACE, which I won't review here, given wanting to get through all the questions, but the idea of overlaying that into a small home type nursing home model, using technologies. I'm not one of these people who thinks, technology can get us all like, we're not going to have robots walking around providing, bathing assistance for older adults. But I do think there are ways that technologies can definitely be leveraged in our nursing homes. We did a study, for example, of telemedicine that was very promising in terms of providing access to clinicians off hour. There's other ways to do this. So I love these kind of models that blend kind of our best community models like a PACE with our best nursing home models that are like a greenhouse or smaller home models.
Okay, now there's a couple of chat questions that are a little bit lengthier, but I think you might want to comment on.
Sure.
What do you think is the ideal patient to staff ratio in a nursing home? Should there be more CNAs assigned, or how do you increase staffing when there are cuts due to low building census?
Yeah, so the answer is usually yes, right? We need all of the above. We need CNAs, we need LPNs, we need RNs. And I'm definitely not one of these people who thinks, and this is what's been unfortunate. When we put minimum staffing standards in place, we've often done them at the overall staff level. And so not surprisingly, facilities have responded by increasing their nurse aides at the expense of RNs and LPNs. We need all, we have too few of all of the different staff types. So one of the things I've called for is new time and motion studies where we can really determine to the questioner, what's the right number? I think most of the studies were done 20, 25 years ago, like the STRIVE study. They're very outdated in terms of the needs of residents. And so I know the GAO is working on this right now. I would love to see us update that work and really get a handle on what is the right rate. If we're gonna go forward with minimum staffing standards, we want to know the right level. But in terms of whether I think, it's clearly, I think all of the above. I really believe that RNs, LPNs, and nurse aides. I ultimately think we're going to need more of all three in the building, and that's kind of what the data to date have suggested, that we have shortages at all three levels.
This will be the final closing question, and then I'd like you to just add any closing thoughts you'd like to have. How do we rebuild the public trust in nursing homes?
That's a great question, and I'm not picking on the questioner, but by rebuild here, I don't know that we ever had that public trust, right? But it's a great question, because I think a lot about this, like how do we actually engage individuals in kind of nursing homes. I've never, over the past year, we've never had more attention on nursing homes and long-term care more generally. that they pointed out a lot of problems, but that's also there's an opportunity here, and that opportunity is to actually fix this. And so I'm convinced that going forward, many more families are going to treat this as an issue, a voting issue, that you need to pay attention to this, because I really believe this has been a forgotten issue. And so I think historically many have viewed long-term care as a family issue, and that I deal with it and each of you deal with it with your own families. But I think COVID has taught us this is also a policy problem. And if we don't kind of fix the resources that are out there, the services, the ability to navigate this system, we're doomed to just go through this over and over again. And as I said earlier, nursing homes weren't that great prior to the pandemic. And so I would love, and maybe this will be my final closing remark, Vicki, that I think, I have an 8-year-old daughter. I think if I went and asked her what she thought a nursing home was, I don't think I'd like the answer she gave me back. And that's part of that public trust that the questioner was asking about. We all have a very distinct view of a nursing home, and I don't like that view, that it's a big kind of institutional place, and it's kind of a place you're put and you go to die. And we need to move towards a more home-like environment where individuals are supported, staff are supported, individuals are able to control and have autonomy over their life and have dignity. That's the model. The current model that we have is a complete failure. And so when I talk to people about nursing homes, they're not even aware of these kind of small home type models. And so if we want to improve public perception, I think it starts with some education around. I would love for people to have a sense of, come visit a greenhouse, come, actually step out to these alternative models. And there's a reason people are, calling nursing homes death pits and these kind of things. It's because they've never been, I think, to a model other than these big institutional models that, as I said, are outdated, and we really have really failed in a lot of ways our residents, but also our staff. So maybe I'll stop on that point and say one of my hopes of the post-pandemic period is that for the first time we really invest in supporting nursing home residents and staff, and that it's an opportunity to kind of reimagine what the sector might be. So I look forward to working with all of you on that goal.
David, thank you very much for your time, your insights. This was a stimulating conversation, very thoughtful, and I appreciate the audience's questions. Clearly you sparked some very important issues that we need to think further about. And thank you for your great work and sharing it with us.
Well, thanks everyone.
Thank you, David.
Bye-bye.
Bye-bye.